Snakes, they have neurotoxins, and it's very unique. It is very important to understand what sort of neurotoxins that you have in your region, because the management is different. Because of the mechanism of action is different. So if you look at, so we have two types, either presynaptic neurotoxin or postsynaptic neurotoxin. So the presynaptic neurotoxin, which is mainly phospholipase A2, and the postsynaptic, which is mainly polypeptides. So talks about the perisynaptic neurotoxin. What they do, they come, attach to the presynaptic membrane, enter into the cell, damage the synapses, release the acetylcholine, causing a surge of acetylcholine, depleted, followed by paralysis. That process is irreversible. As soon as it starts and the damage happens, it is, as much as you give antivenom, it's not going to work. And you just need to wait for the axons to start to repair, which just takes days, weeks, or whatever. In reverse, the postsynaptic, they block the receptors on the postsynaptic membrane, so they stop the acetylcholine from working. So displacing the acetylcholine from that receptors will give you a recovery. So giving antivenom, anticholinesterase, which some people try, will help, is a form of a treatment. So that's an extremely important distinction that one has to make when looking at the neurotoxins. So presynaptic neurotoxin usually take more than an hour to develop by the toxin to reach the motor in the plate and start to work. And as we said, this is the damage cannot reverse. If damage starts, you can't reverse it. And good example, your crates, your tiger snakes, and taipans. The postsynaptic neurotoxins, which we're mostly talking about the cobras, they are polypeptides, Dendrotoxin and cobra toxins. And as we said, they attach to the postsynaptic membrane and they block the receptors. You displace them, you get some recovery. Now it's been, I don't know from experience of the panel here, but it's been postulated that the paralysis you get with the presynaptics tend to be worse and more severe, and probably that has something to do with the way that they damage the synapses completely. However, there's published data now with the cobras that they are life-threatening. Paralysis has been documented with the postsynaptics neurotoxins. There are other two types of neurotoxins, dendrotoxins and fasciculins, and good example for those is the mamba, the black mamba, the African black mamba, where they work synergetically. So the dendrotoxins will do the presynaptic effect, they will go into the cells, they damage the synapses, they release acetylcholine, and the fasciculins will block the anticholinesterase. So the surge of the acetylcholine will continue, and that will give you the paralysis. It augments the paralytic effect. There is the Taiwan, the Chinese branded crate, has a unique neurotoxin. Anybody knows what is it? It has both the pre and postsynaptic neurotoxins. And this is a unique thing for the Taiwan branded crates, or Chinese branded crates. Time of onset of paralysis, as we said, it may take more than an hour. It usually starts with tingling, numbness, sensation, then the cranial first to start to get affected. Bit of ptosis followed by ophthalmoplegia. 6 nerves usually start to affect first, and it progresses from there on. And then you start to lose your reflexes, and you start to have respiratory depression and death. And this is the best example how to start with your ptosis, your ophthalmoplegia left the 6th nerve palsy, faceless or expressless faces, and then fixed dilated pupils. So that's pretty much about neurotoxins. Then you have the myotoxins. And the myotoxins, you have the two types. That you have the local and you have the systemic. Systemic associated with potential is devastating and lethal. And the locals, it works on different effects. Before that, we ought to say not only skeletal muscles get affected by myotoxins. Although smooth muscles very rarely get affected, you have the cardiotoxins. There have been documented cases of severe cardiotoxicity and cardiomyopathy following snakes envenomation. Though it's not clear whether that's a direct effect or indirect effect of being sick and etc. Having said that, you have the local myotoxin and the systemic myotoxins. The local myotoxins, the most important, the snake venom metalloproteinases, which we're going to talk about later, which have both direct and indirect effect. So it causes damage to the muscles by this, myotoxicity, plus the edema and the ischemia surrounding it, and the hemorrhagic effect on capillary leak. It will give you the indirect myotoxic effect. Local myotoxin cause damage to the basement membrane. The systemic myotoxins, they don't do that, and there is some differences, and we'll show you it later how that's important. And then you go to the systemic myotoxin, and there are two types here. The ones which are pure myotoxins, they go systematically, but they don't affect anything else apart from the muscles. And the phospholipase A, which affect both. The presynaptic neurotoxin also have an effect of the muscles. Now, it's been postulated that the pure myotoxin is more associated with more severe rhabdomyolysis and muscle damage effect because the presynaptic, the mix, they have the diluted, the acceptors of the enzyme, the enzymes are different, so and they don't cause damages on other organs or other tissues, so you get a diluted effect on the muscles. Not sure how true is that. So chemical types of myotoxins, we said there's some cardiotoxins, the phospholipase A, and non-neurotoxin myotoxins. Not going to dwell too much on that. And this is an interesting slide. Tiger, I think. Yeah, a tiger snake, phospholipase A2, injected into a rat's skeletal muscles. After 3 hours, the damage, 24-hour transverse section, and 24-hour longitudinal section. Yeah, so we discussed this, that some of the myotoxins, they don't specifically attach to certain acceptors and attach to many acceptors, but the damage only on skeletal muscles, acceptors or receptors, and you end up with a systemic muscle effect, but that not necessarily a severe one. The ones who are attached specifically to certain acceptors on skeletal muscles, they tend to cause more systemic effect because of the concentration phenomena. With systemic effect, the basic membrane remain intact, so regeneration is muscles can occur. However, you get a regeneration only of slow twitching muscles, and this is an effect of the long-lasting effect of the systemic myotoxic of snake bite. And when we talk about myotoxins, we talk about rhabdomyolysis, which can be severe, very, very severe, and end up with renal failure, hyperkalemia, etc. And the long-lasting effect of muscle wasting if the inflammation was severe with systemic effect. Urolipids, many Australians, lictrates, sea snakes. Do you see Ashish in India?
Sea snakes? No, we don't.
No, so your crates, do they cause myotoxicity?
No, we haven't seen any myotoxicity with crates.
No. The vibridii, some Americans, rattlesnakes, or American colleagues, myotoxic effect is a lot.
You see it, yeah. You actually can see myokemia with lots of even the non-Mojave rab snakes.
They do?
you see muscle breakdown. CK goes up all the time.
Yeah. Talking about the hundreds of thousands, obviously.
What was that?
The CKs.
CK goes actually in the tens of thousands, not hundreds of thousands.
Okay.
It's not as
and the
severe.
long-lasting, is there the systemic long-lasting disabilities effect of muscle wasting?
Very few chronic effect that we see. There's some local effects in terms of if it's your fingers, toes, you see some waste is there, you can see some.
But that's most of the probably a necrotic effect.
Yeah, it's not. And very rare you see like neuropathy here and there because post-acute inflammation.
Yeah, that's correct. Okay, interesting. So the coagulopathy, and this is an interesting subject. And as I was saying earlier, the snakes in their evolution, they did not intend evolution did not bring them to the point that they wanted to cause coagulopathy in their prey. It does not serve them any purpose. The effect of the same venom on the small prey is completely different on a human. They wanted to paralyze the prey and get it eaten. They're not interested to let it go for bleeding for a day or two. So your consumptive coagulopathy, thrombotic, anticoagulant, antiplatelet, and direct hemorrhagic effect. And you can find a single toxin which has two different effects and augment its action. We'll talk about it in a minute. Most species have hemorrhagic effects, hemorrhagic toxins. So, for example, the metalloproteinase prothrombin activator of the icky species has also a hemorrhagic effect. So the concept started the concept of coagulopathy that activate the prothrombin activators throughout the coagulopathy, the consumption. Meanwhile, the hemorrhagic cause the damage to the blood vessel wall, give you a shear stress effect, and that will augment the bleeding. So you get worse bleeding. And in a study, they compared the efficacy or the potency of the prothrombin activators of the Australian elapid and the ICIS, found that the potency of the prothrombin activators in the ICIS much more potent than the Australian. However, the bleeding is worse with the ICIS than with the Australian elapid, and they put that down to the effect of the augmenting effect of both the consumptive coagulopathy and the hemorrhagic effect. It used to be called BIC, which is wrong descriptions, and it's basically that you activate the coagulation cascade to the point that you consume all of your coagulation factors. And you have three types of activators: the prothrombin activators, the factor 10 and 5, and thrombin-like enzymes. And you end up into that circle until you consume all of your factors. And it's give you somehow clinical biochemical picture similar to DIC, but it's not DIC, because as you know, DIC is associated with multi-organ failure and it's associated with much worse prognoses. So we've discussed that earlier. Don't want to go through it. Now, anybody has any experience using point of care INR for snake envenomation? I don't know. It's just interesting to mention it here. It should not be done in snake envenomation because of the fact, and this is proven. There's a couple of studies on this. Because of the fact is the laboratory tests on INR test the clot formation. So you get the blood, you get the plasma, you add to the tissue factors, and then measure the time to form a clot, and that's what you need. But when you use the point of care, it will give you. They will add the tissue factor, and then they will add a substrate, which is electro substrate, something substrate, and then they see the cleavage, the thrombin cleavage of that substrate, and they measure that. And that's the wrong way of measuring INR in this situation, because thrombin is always there. But you don't want the thrombin, you want the clot. So it gives you a wrong reading, and it tells you it's normal, while it's not normal. So point of care of INR is pointless. Sorry to mention that as well. I thought it was a bit of an interesting point. Although you might be bitten by snakes as hemorrhagic or hemostasis effects, not all of them can give you the clinically significant bleed. Some of them get unseen. And this activity of the bleedings might cross over with the necrotic effect, the cytotoxic effect. You get bitten here, there's some necrosis, you have direct effect on the blood vessels and start the oozing. And as soon as the systemic effect of coagulopathy on the antithrombotic or the antiplatelet aggregation, you start this get worse and worse. In terms of necrotoxicity, not well understood, but it probably is related to phospholipase A2 and the metalloproteinases, which has several reaching effects, so we're going to discuss briefly in a minute. And also the secondary effect. It used to be thought that the necrosis or the local effect is not of a significantly clinical importance, but that was, again, a misconception. It has a major devastating effect on the life of the person who's getting bitten by venoms, which has a local necrotic effect, not only from an immediate clinical point of view, where you have fluid shift and you have hypotension and shock, infection, which can be devastating. You end up with severe morbidity and mortality. And for these areas where the most snake inflammation happen, these people are manual laborer, and any form of disability is a devastating effect on them on their family. So, and as you know, there are several snake species who are linked with local injuries, and that span the whole 4 species that we have. So the hemorrhagine metalloproteinases, SDM, there are 4 classes, and the effect is they have a wide range of effects, some of them locals and some of them not local, and it is in a way, main effect is to immobilize the prey and digest the prey. Another interesting fact is that the vipers and culprits feed on what they call type 3 prey, which is big and heavy-bodied. So they need an enzyme which can digest the prey. So they have they have prominent SVMPs in their venom. The elapids, they usually tend to feed on elongated low volume surface to ratio, and for that they don't need a potent SVM to digest the prey, so it's not a prominent toxin. And we talked about the effect of the CMV. They damage the basic membrane, cause local hemorrhage, shock and secondary effect, ischemic change, and direct and indirect injury. I think finally the renal toxicity. Again, there are some renal toxins, and it's been proven that there are some renal toxic enzymes. However, from anecdotal evidence and from some literature data, the most prevalent is a secondary effect because of the shock, the infection, etc. And the pathology is varied between acute tubular necrosis to bilateral cortical necrosis in severe inflammation. I don't know if we have a Turkish. No, we don't. So just for interest for the people here, they have in Turkey. They have mainly the vipers. think they have 11 vipers types, and they have the one cobras more than there's a cobra. In terms of the vipers, the procoagulants and hemorrhagens, that's the main toxins, and their neurotoxic is post-synaptic neurotoxin. Just the last couple of slides, just what to tell. This was not intended for you guys. It was intended for general physician or AR physician. But just want to tell them not every bite is a wet bite. Not every bite is going to give you inflammation. There's some studies suggest up to 80% of soft-scale viper inflammations are dry bite. And there's a lot of various reasons why can that happen. So not every bite has to be given antivenom. And unfortunately, for our colleagues from the West, the cultures in the Middle East and here is, when a patient comes, you want to do something, and you show the family that you're doing something. And this is huge impact on the decision making for the doctors. So when somebody comes with snake, to come to the family and give it to teach them, oh, this is a dry bite, it's nothing, we'll wait and see. You are unlikely you're going to get somewhere with that. And if anything happened later on, it's not like you've evidence-based your decision. You made a mistake. And that has an influence on decision making. And I was with Badria just recently in the emergency Society of Emergency Society, the Emiratis one.
Emirates Society of Emergency Medicine.
Yeah, we did a track on toxicology and we talked about inflammation. And after that, 3 people came to me, 3 doctors who works in the peripheries of the main cities, and they told me that they had same experiences, copycat. Inflammation, dry, no symptoms, whatsoever. And all 3 of them, they gave an antivenom. All 3 of them. And then I asked them, all 3 of them, and then I asked them, I mean, I just tried to elaborate, and they all say the same. It's a family pressure or something down that line. So it's a way to go. I think we've discussed this. I don't need to dwell about this too much. Anaphylaxis, that's a very important aspect that can happen with any snake inflammation, and the management is following your SELS, and it is a feature of systemic inflammation, and it's an indication of antivenoms, a topic which Dr. Ashish will talk to us about it. Thank you very much. I'm sure you don't have any questions. I'm sure you.
Just going to kind of some of the slides I'll rapidly skip through. Touch our life in Southeast Asia, every possible way. Worshipped as God in India, and yesterday was Mahashivratri, where you worship actually snakes, right? Source of living for many, food for many, wine, and then lots of movies. Right now, currently the number 2 ranked serial in India is on a snake, right? And then there is fashion, jewels and tattoos and pets. And this is me.
Someone is holding it.
Much younger.
Much younger.
Yesterday.
And the deadliest animal in the world is human. So, so this is a person who was a priest in a local temple. Probably had developed immunity because he was maybe bitten again and again and again. But why did the cobra die?
Nobody knows.
Nobody knows. These slides you've already seen, so I'll not show them again to you. You know about what are the 4. These are the major snakes in Southeast Asia. King cobras, vipers, common krait. This is what I was talking about. This is a hump-nosed viper, which we see This is Pangarus sindanus, which is mostly common in Pakistan, but in some parts of Rajasthan you see these snakes. And we don't have venom against them. Now this is what you were talking about, dry bite.
Yes.
Do we ever document a dry bite? I have not seen a dry bite till date. What do you mean by dry bite? Is that you have a person who's actually witnessed bitten by a venomous snake and does not develop any. Since I work in a tertiary care hospital, most of the time people reach me when they have something. So what you were talking about was that people who are practicing in the periphery,
That's correct, yeah.
they would be seeing most dry bites. And this is a wonderful article. I don't know if you have seen this. No envenomation, no local silent symptoms. That's dry bite.
We see this in Europe.
You see it in Europe
because I think people go to the events as soon as they're
yes.
So we see.
So this is a review article where they have reviewed the complete literature and say that there could be a natural immunity, there could be absence of venom in the gland at the time, it could be a diseased venom gland, the fangs may be broken, or there could be a mechanical failure. Or then one of them was, one which is not here, is that maybe the snake misjudged the distance between the victim and has probably already injected it somewhere, and the second time when he bites, it's a dry bite. So what are the problems? Identification, first aid, definitive management, and the supportive treatment. I don't know what happens with you guys. In India, this is the problem. At the time of monsoons, you have these kinds of growth all over. Their burrows get flooded and they come out in big numbers. And they enter your home in search of food. They are not interested in biting you because they can't eat you. You get accidentally bitten because you are in their way. Right? So this is, we see majority of our, I'm going to present that in the EAPCCT meeting, majority of our snake bites are within 3 months. And that's it. It starts at the onset of monsoon, with the end of monsoon it's over, and we don't see any snake bite in between. Occasionally,
in a tertiary center, but in a periphery they still see.
I have not any idea, because most of the time they are referred to me from the periphery. So if they don't see it there, they won't send it to me. Very occasionally we get some viperine bites or cobra bites in the winter time from the handlers, not general public. General public is monsoon.
So that's interesting, because we in Arizona also have monsoons.
Yeah.
We actually call them monsoons. And we don't see a correlation with that. As a matter of fact, our season starts around mid-March and goes to about October.
Wow.
And the peak of activity, snake bite activity, is peak when we see people going outside performing, which is not too hot, and usually people don't go out during the monsoons and right after the monsoons because of humidity. But when it's nice and warm but not too hot,
then they get it. Okay. Now the first principle is identify your susceptible population. For us, it is males, rural more than urban, workers in the field. Most of the times, in one study from Baviskar, most of the times the people who are harvesting time, that's where you get bitten. You either get bitten on your left hand, and he showed at one particular meeting that he got in an hour's time 3 women who were harvesting, and all of them were bitten on the left. Because what happens is, when you grab the wheat or rice and you want to cut it, so you end up grabbing the snake or touching the snake, and that's why your left hand, with the right hand you are kind of, so you need to identify. For us, for me, in Chandigarh, it is this. construction site workers. Most of the times, because they have they are staying in small makeshift rooms and no doors, no nothing, they're sleeping on the floor. And in the monsoon time, the snakes also want to come out and be on a dry land, and that's the dry area, the floor where they are sleeping. So that is where they get, or workers in the forest. We don't have any big forest nearby. Sometimes we get from the forest in Himachal victims, and that is occasional victims during the other times.
So that's interesting, because I just reviewed about 1,000 envenomations, recent envenomation. In the US, it was sexy, what I call trash bias gets replicated all the time. And it was we had this derogatory 7T, testosterone, intoxicated, tequila, nonsense, really. That because it was sexy, everybody reproduced it.
Yeah.
I looked at our data, and our data shows that these are people who are doing landscaping, golfers, gardeners, hikers. So ours is also, to a large extent, people who are doing what I call industrial activity or work activity, and then leisure activity. I actually presented that about 3 years ago at it was in Dubai. It was the International Society of Occupational Health. Had that conference we presented. But in the US, the same trash gets recycled and regurgitated all the time.
But we have a lot of our army in the area which is dealing with, and it's if you know the Maoist area, the right-wing area in the eastern part of India, lots of forests there, and the terrorists are hiding there. The police and army is behind them. So all three get exposed. So all three
The terrorist comes to your hospital?
We treat
I'm
him.
a terrorist.
Well, we see, I don't know who you are, right? If you are here with me as a patient, I have to treat you. You might be a terrorist, I don't care, right?
They don't have a bandana, say I'm a terrorist.
Now this is again which is very important. I think when you're making a sheet, you should know this, that you need to include comorbidities. Most of the time the armies, the policemen, they are active people, they do not have so much comorbidities. Construction site workers, who will work at a construction site? A person who is healthy. A person who's got diabetes, hypertension, coronary artery disease is not going to go and work there. So, but if you have comorbidities, this is again important, the part bitten, what we looked at, our data, that if you get bitten on the foot or on the hand versus you get bitten on the ear or on the scalp, you're likely to have more severe inflammation, right? So this is what we realized, that near the face, you're likely to have more severe inflammation. Then you have individual sensitivity, the species, and then the secondary infection. What kills most of the patients with viperine bite is not the bite itself. It is renal failure and it's the secondary infection. Principle number 2, snake identification is difficult. You try to identify snake whenever it is possible. They run away, they bite at night, so they get killed, crushed, so sometimes, but if you have a snake which is brought to your ED, preserve it. Preserve it and send it to a herpetologist or maybe a picture to them.
Have you had somebody brought you a live snake?
Yeah, we've got. I'll give you an example. There was this guy who came in, had classical symptoms of envenomation, and said, "Did you find a snake?" "No, I didn't." Like, okay, want to? He says, "Just some itchiness here." He took off his vest and there was the snake there. Live snake in my ED. It was a small snake, crate. And it was chaos. Everyone just ran here and there.
It's like the worst thing.
Yeah. So clinical toxidromes sometimes do overlap, and venom assays we don't have. I don't have a venom assay. I don't know whether you have a venom detection.
Australia, I don't know if in America they have. Australia, I think they only
Australia, they have venom detection kits.
Yeah.
Right? I'll tell you why we can't use venom detection kits, or very limited use for us in our. This is general symptoms remain the same. Viperine bites, you may have cardiovascular effects in the form of arrhythmias sometimes. Bleeding, clotting disorders have been already talked about. This is the picture which was again shown. I had a picture of a real patient, a video of him, but the thing is my laptop crashed, so I can't put that, so I picked up. Now this is sometimes one of the manifestations of viperine bites, and it doesn't progress beyond that, right? So if you have a kind of Russell viper's bite, having neuroparalysis,
Yes, it does happen. Yeah.
but it does not, it just goes to ptosis, and it does not have very severe respiratory paralysis as compared to the crate and the cobras, which cause very severe respiratory paralysis. This we have already seen. This happens with Russell's viper with us quite a lot. This is what we published. I don't know if any one of you ever read this paper or not. We published it in Endocrinology, that in the chronic phase, following a Russell's viper bite, there is something like a Sheehan syndrome, which these people develop. It's initially a hemorrhage, and then they go on to develop these kinds of manifestations. So we did a study over 3 years' time, collected all kinds of viperine bites, followed them up, and found that there is a definitive evidence of a pituitary dysfunction. So if you don't have the venom detection kit, if you don't have anything else, how do you identify? What we use is this: paralysis, severe local envenomation is, or necrosis is, cobras do cause tissue necrosis, and severe local envenomation with descending paralysis. This is what I see every day. Every day. You know, very interesting thing. I walk into the ED one day, and there's this my resident talking to a family, saying that we can't do anything for this guy. He's brain dead, right? And I start talking to him and say, "What's happening?" He says, "This guy slept at night. In the middle of the night, he wakes up with severe abdominal pain, vomits." And the wife says, "Maybe you've eaten something, which was not gelling with your GI tract." So go back to sleep, gives him something, and goes back to sleep, never wakes up in the morning. So this patient had dilated fixed pupils, no doll's eye, cold calorie negative. And they were sending him home, that this guy is brain dead. So hold on, give him anti-snake venom, put him on a ventilator, and 96 hours later, he walked out of the emergency. So a person who was declared brain dead was not brain dead. He was just having severe ocular paralysis. And that's why you were not getting anything which was, his brain was intact. Nothing wrong with his brain. But if he was not given ventilation, he would have died. And it would be hypoxic kind of death. We had one death in hospital in a crate bite victim. We ran out of the ventilator, so we were giving them manual ventilation. The person who was doing that fell asleep for 2 hours. And that lady went on to develop severe hypoxic damage of the brain. She was put on ventilator and things like that. She never recovered, and she died of complications of ventilation rather than the snake bite itself. But she had suffered, we had an MRI done. She had a definitive evidence of hypoxic brain damage.
So, Ashish, are they bringing you the patients then within a period of time?
I'll come to that.
They're not hypoxic?
No.
Okay.
Rhabdomyolysis, I'll talk about that also. Renal failure, rhabdomyolysis, it could be sneeze snakes, could be Russell's viper, shock, bleeding, coagulopathy, renal failure, and severe swelling. Local swelling is viperide, and then some amount of neurotoxicity may be there, as I said earlier. This is very important. First aid, what are the guidelines? Hardly any guidelines. This is a review article published in Tropical Medicine. It says definitive evidence is this: splint, rest and avoid movements. That's it. Just splint the limb. What is a natural reaction if you have somebody running after you? You run. What is the natural reaction if somebody bites you? You want to get away from that place, and if you know it is a snake, you want to run as far away as possible. When you start running, that's when the damage starts happening. So you have to splint, rest and avoid movement. Now this is pressure immobilization is written here, but you have to be very careful. You don't want to very tightly tie a tourniquet.
Because just for our colleague, in America, this no.
What?
The pressure immobilization.
Yeah.
It's a no.
No, we still say, but no
There's a
tourniquets.
position statement
No tourniquets,
on pressure
because
immobilization.
tourniquets can cause.
No, even pressure immobilization. This is the Australian one. In America, they have a position statement
We don't do it.
because of the local necrosis.
Yeah, I'll talk about that in my...
Yeah.
So then there are these two new things: topical nitric oxide inhibitor and trypsin injection locally. But there's, as far as possible, don't do anything in the field, because you don't know what you'll end up with, right? Why I was telling you it is important to involve the herpetologist and know. This is the data which has come from India, from the snake park in Chennai. Now they milk these snakes and they find out how much is the maximum amount of venom which is there, after a week or after a month, whenever they milk them. So you find that Indian cobra, it is 60, common krait is 20, Russell's viper is 63, and saw scale viper is less. So maximum around 60 milligrams is with cobra and viper. Why is that important? It's important because when you want to devise your anti-venom properties, you need to know what exactly you want to give and how much maximum. Although the fatal dose is just 12 milligrams and 15 milligrams. But you want to neutralize what the snake can inject maximally. And that's where your herpetologist will tell you. And then you can decide, based on the calculation, that how much of venom would, 10 ml or 1 ml of your anti-snake venom neutralize. So that's how you make the calculation regarding the doses. So Indian snake, anti-snake venom against cobra and against Russell's viper, 1 ml will neutralize 0.6 milligrams. So if 1 ml neutralizes 0.6 milligrams and you have 60 milligram as the maximum dose, so you need to give nearly 100 ml. That one vial is 10 ml and you give 10 vials. That's the way calculation was done, right? But you need, this is known. This is known, but what the snake has injected until unless you have the venom assays and the venom levels, you'll never know. So if you have a venom assay, and if you know that how much is the circulating venom present, you can titrate your anti-snake venom dose. If you don't know that, then you need to make calculations based on what can maximally be injected. So that's how our treatment protocols have been devised.
How do you calculate the fatal dose in human? How do the lethal dose in human?
There is the 50?
Just
This
How do you
Well, it's extrapolation.
it's the extrapolation.
Extrapolation from.
They have not done the venom analysis. This is just the extra. What is known is this, and what is also known is when you make your anti-snake venom, how much of 1 ml of anti-snake venom will neutralize. Now you have this much, but you may not inject that much per person. But when you are giving anti-snake venom, you need to cover. Again, this is a normal, natural kind of a snake which has been reared in a snake park. Now, if this snake hasn't had a meal, if it is dry weather, then the venom would be far more concentrated. Right? So you get that. So
The venom content is actually, both the content and the amount is different in the wild type versus
versus
the capture.
Yeah.
I've known that for a long time.
Yeah.
And you know, I agree with you in a sense that if you don't have anything else, but if you have clinical trials, you actually, it's based on severity and what really happens in humans that you can determine the dose of the antivenom or how many vials. This is in lack of having clinical trials. And I think we keep doing this to ourselves. We need clinical trials.
The problem with this kind of a trial is that if I don't know what is the venom concentration, how can I lower the anti-snake venom? Then it becomes a trial and error. You know, I give one person 10 vials, 100 ml, and I give another person, 5 vials or 50 ml, and then see what happens.
Well, we do it in clinical trials based on severity. That's why we come up with trauma, like ICU, we come with either snake bite severity scores or other clinical scores that will guide you. And then it's based on the practical activity rather than potential.
Okay, I slightly differ from you on this. We have cases who come to us early, have just doses. We give them anti-snake venom, and within 2 hours or 3 hours, they go down to in spite of giving them 100 ml of antivenom, they're going down. And they go down to develop severe paralysis. Right? So,
But what's the harm, sorry, the question, but what's the harm of having that graded severity approach if you are
that's what I'm saying. So, if I have a graded severity approach, and if I say that if a person presents to me with ptosis only, I'll give him 5 vials. And if he has full-fledged paralysis, I'll give him 10 vials. I'm delaying institution of maximum amount of antivenom by a couple of hours.
But you're reducing the risks of side effects, you keep your antivenom storage.
You are weighing the risk of
You are weighing the risk and benefit.
And that's what you do also in clinical trials.
Yes.
Clinical trials are designed, and then you look at it and see whether your patients are moderate, severe, okay, mild, and you don't make the recommendations based on a mild. Right?
I'll show you the data again a little bit later. So, principle 5, whenever you get a patient in the emergency, reassure, use IV injection, look for respiratory risk. ABC is the airway kills first, right? So ABC remains always. You have persistent vomiting, you can give chlorpromazine. If you have syncope, shock, angioedema, you can give adrenaline. Clinical assessment, again, is something very important. How fast the swelling is progressing. The swelling starts within 15 minutes, but it may take up to 2 hours, right? This is very many times the patients are bleeding in their mouth. You don't even see that. You don't even ask them, until unless they bled enough and they're spitting it out. You won't even look at that. This is something which I haven't encountered too much. Regional lymph nodes. Although it is mentioned, but I don't.
I've seen it with the European ones, European other lymph nodes.
We see that all the time with the American crowlet. As a matter of fact, some of the worst bites I've seen in terms of local effects is women who have gone under mastectomy and lymph removal. They actually have much faster development of local effects than a person with the intact lymph node.
I haven't seen too much of sea snakes, so I don't know how much trismus and generalized muscle weakness, because we stay way away from the sea. This is what I was talking to you. Whole blood clotting time has its problem. But in a clinical setup, this is probably, we've done trials, my colleague has done trials on thromboelastography and measuring INR versus the whole blood clotting time. So if you talked about the point of care, we don't use point of care, use lab INR. And lab INR, if you can get done, is more sensitive. But as you said, that if a person comes to you early, may not have developed consumptive coagulopathy, may still be in the phase where the coagulation is going on and they, all the factors have not been consumed till now. So your whole blood clotting time may be normal in the initial phase of a viperine bite. But you need to repeat it. You need to repeat it. So that's very, very important. Always examine urine for both hematuria and myoglobinuria, because viperine bites can also cause IV hemolysis, right? So that's antivenin. We all know this. This is what happens. 1 ml of antivenom. These are studies which have been done over a period of time, and 1 ml neutralizes 0.6 milligram of cobra and 0.6 milligrams of Russell's. So if it is 60 milligram maximum, you give 100 ml. These are the indications for giving this. This is very important, dose of antivenom. Now there are lots of issues with how do you dose antivenom. This National Snakebite Protocol was developed around 15 years ago with the help of Ian Simpson, who's a herpetologist, who talked to people all over India, looked at how much was the snake venom which could maximally be injected, and what were they doing. So what they said, that if you want to neutralize 60 milligrams, you have to give at least 100 ml stat. Now you have to, what you said, that the snakes which are inbred and the wild type may be different. So you reassess after 2 hours if the paralysis persists or increases. Well, there are only 2 snakes which can cause paralysis. That is cobra and crate. And if you look at the amount, 20 milligrams, right? So you need a much lower dose for crate bites. But you don't know. You want to cover cobra. Although we don't see local envenomation. So your point that you want to rationalize giving antivenom, could do a trial on this by trying to neutralize only 20 milligrams and not 60 milligrams, which would again be different dosage.
In your center, what's the average number of vials?
I won't finish? Okay. This is what I was telling you. This is what it is. This 2001, 900 ml.
The average.
900 ml. That is huge. 90 vials. Right? 2005 came down to 500 ml. Then they did a trial, the same group. They gave 150 ml in 28 patients and 600 ml in 27 patients. Now we've come down to 200 ml. Because that's the guideline. It says that you give 100 ml up front, right? And then you give 100 ml again in 2 hours if the paralysis is.
But what's your endpoint? What are you comparing?
Comparing?
Yeah. Besides the patient walking out. Okay.
Mortality.
You gave 900, they walked out. Mortality and the duration of hospitalization. I haven't presented here, but I can, share with you what was the total duration of hospitalization, which was much higher in all this, and it has come down here.
Did the time of the presentation affected the outcome?
No.
Or the amount that you are giving?
No, because we are following this standard protocol everywhere. But the recent guidelines which have come from the Ministry of Health, not for the neuroparalytic snake, but for the viperine bites, they have decreased the follow-up dose to 6 vials. From 100 ml, they've decreased to 60 ml based on whatever a little bit of clinical trials which have been.
And these are FAB2, right?
Yeah.
FAB2.
Yeah. So this is the total cost. Okay, I'll not talk about this. This is important. Ventilation works in neuroparalysis. Now, when I was given this talk, Ziad gave me a question. How do you deal with snake bite if you don't have an anti-snake venom? Now, we talked about the crates causing the presynaptic destruction of the nerve terminal. There have been studies which have been conducted in Sri Lanka, and they've shown that the nerve terminals take anywhere between 72 to 96 hours to regenerate. So you don't have an anti-snake venom, don't do anything. Ventilate them. They'll come back, right? With the anti-snake venom, the average duration of ventilation in a crate bite is around 36 hours. So if you want the nerve to regrow, you might have to ventilate them for double or slightly more than that. And then there'll be associated complications with ventilators, right? Long-term ventilation. But if you have nothing to offer, just ventilate. And why ventilation works in a crate bite victim? Because their lungs are clear. They are not ARDS patients. They do not have dirty lungs. They do not have anything which is flooding their alveoli. It's just that the muscles are not working. And the ventilator is doing that muscular. They don't require very high FiO2. They don't require very high rates or pressure. What they require is something which can work as their muscles. This is the mortality. It was 3.5%. It was 11%, and this is the last study, 2.73%. This is what you were asking. What was the mortality?
Yeah.
In different studies when you were using different kind of ventilators. So it was 3.5%. There in this group where they were using high dose of antivenom, the mortality was more. So we have kind of come back. Okay. Yeah. Look for complication. Look for antivenom reactions. This is something which has again come from Sri Lanka. We don't see too much of it, but it has come from Sri Lanka that people who have been, we followed up our snake bite patients. I haven't seen anyone coming back with these issues till date to me. We have a very big rheumatology center and we initiated this, that any new patient who comes with any of these arthritis or mononeuritis or any kind of a problem, then were you ever bitten by a snake? Did you receive anti-snake venom? Till date, we haven't kind of found this. But somebody's come out with this, that this can happen. So there is a possibility that there can be a long-term. Look for hypotension, look for oliguria, look for local infection, look for compartment syndrome, and then some other unusual complications. So if you see a snake, don't panic. Do not disturb it. If the snake is moving towards you, stamp the ground. This was for the president. This can be, for the general public. Yeah. And avoid stepping, protect yourself. That's it. Thank you.
Thank you very much, Ashish.
To give you our perspective and how we have kind of gone from very high to reasonable anti-snake venom. We probably try to reduce it further.
We are trying to do a randomized control trial. There are two doses of the snake antivenom because the guidelines in they give us for severe envenomation quite a huge range between 50 to 100 ml of the snake antivenom. And so we are keeping it up to the physician to decide.
And each vial has what, 10?
10
ml.
Each vial has 10 ml.
10 ml, and how much protein in each one?
I think 14.
What's the question?
Protein in each vial of anti-snake venom.
Saudi snake antivenom.
Paul, do you want to make your presentation before or after the break?
I'll do it now, if that's okay. Okay. Unless you want to take a break, I want to answer. Thank you very much for inviting me to give this presentation. I think I don't really need to give a presentation because it's already been given by the previous speakers, but I'll highlight my perspective as well and try to focus in on antivenom. But much of the key teaching points have already been presented this morning with two really excellent talks. So I'll just start off with this slide about the cost of antivenom. So in the US, which is my experience with treating snake bites, most people who are bit by snakes don't die. So that's not the endpoint that we deal with in the US. In fact, the number of fatalities from snake bites each year is just really a handful. I think they've made estimates of maybe 10 or fewer people from around the US die from snake bites each year. But we still use a lot of antivenom, and the first speaker is real interesting in terms of, well, when someone comes in, is it a dry bite or not? The family wants us to do something, give antivenom, and that's often, the quandary we face when someone gets bit by a snake, or even if they come in with other medical complaints, is the family wants us to do something. But one of the factors with snake antivenom has to be factored in is also the cost. And not only is the basis of the cost very expensive, but then the hospital makes a lot of profit on antivenom. And so while most antivenom cases, they don't spend $143,000 US, the typical amount of antivenom cost may be $10,000 or $20,000 or $30,000 routinely, which is extraordinarily expensive. We associate that sort of cost with open heart surgery or some major operative procedures, and the cost of antivenom is almost that much. So, given the cost of the antivenom, that's part of how I factor in whether I'm going to give antivenom or not. So, I've had the opportunity over the last now 7 years to be part of the North American Snakebite Registry group, and we're a group of toxicologists from around the United States that have been putting in our snakebite cases into this registry. We have about 1,000 cases or so at this point, and we're continuing to enroll cases, and hopefully we'll learn more about snakebite with this large accumulation of data, particularly in terms of treatment. I think our approach, as you'll see, is kind of one size fits all in terms of how we dose our antivenom, but there's certainly subgroups which would be, I think, very interesting. People with coexisting morbidities, diabetics and other folks, and children versus adults, and whether there is a strategy to differentiate how much antivenom to give. So a lot of this is not known. and through the collection of this data, hopefully we'll learn more in the future. I think what I did in terms of my research to prepare for this is that in Turkey, the most common venomous snake is the black viper. We don't see black vipers in the U.S., but we see, as you'll see, mainly the crotalids. So this has already been discussed previously. These are very interesting and very pretty sorts of snakes. But other than the coral snake, which we see in the southeast in the U.S. These other snakes are the exotic snakes, which occasionally people have as pets, or so we occasionally get a call about one of these other sorts of snakes, but these are not native. These are the old world vipers, which have already been discussed, which belong in the old world, not in the U.S. except as exotic snakes, and we see the Crotalidae snakes. And particularly the rattlesnakes and the copperheads, the cottonmouths are less common, depending on the geography of where you're positioned. So in Arizona, for instance, it's predominantly rattlesnakes and their subspecies. Where I practice in Texas, we have a predominance of copperheads, but we also have some rattlesnakes as well. And the venom effects are different between these two types of snakes. The rattlesnake envenomations tend to be more severe than the copperheads. The copperheads tend not to have as much of the hematologic effects, and even the direct tissue toxicity tends to be less with the copperheads. But still, when patients come to the hospital, they get bit by the snake, they bring in the snake, they want something to be done. Do you use antivenom or not? And in fact, many of the copperhead bites that we see, even if they have the local effects, we may choose not to give antivenom, particularly with the copperheads, just because the course is relatively benign. So, thinking about when to use antivenom in the U.S. I'm not sure how good this data is, but approximately we say 20% of the snake bites are dry bites. So my sense of a dry bite is there's really no direct inoculation of the venom per se. There may be some minor physical injury from the bite, but no envenomation. But of those who become envenomated, many of these cases, or some of them, may be mild cases just with some local effects, really without extension, without any systemic effects. In those cases also may not require this very, very expensive antivenom. So these are some of the species we see in the U.S. And in terms of identifying snakes, it's nice to get an identification. We often don't have an identification, and we just treat them as if it's some sort of rattlesnake or a copperhead snake. We've already heard a lot about venom and various proteins and the clinical effects. With the U.S. snakes, most of the clinical effects are the effects causing local tissue toxicity, and for some reason those slides are not appearing. And then some hematologic effects. And the hematologic effects are of interest because you can measure these hematologic effects. We do not measure antivenom or venom levels or any sort of additional information that might be helpful in assessing the severity of the snake, such as a venom load. We don't have that sort of technology. So, but we do look at, obviously, the hematological factors, the platelets and the coags. So in terms of the management of the snake, as was already discussed, we do the initial evaluation. If the patient's been envenomated, we do hospitalize the patient even if they don't need antivenom, just to provide some time to observe the patient to see if there's any progression. If we feel it's a dry bite, particularly if it's in the upper extremity, then we'll send them home after a short period of observation. Usually with the lower extremities, and in children, we'll admit them over to the hospital and watch them at least overnight, even if we don't give the antivenom. This has already been discussed in some detail. The complications we've also discussed again. Death is not a common endpoint at all in the U.S., but certainly the potential for a compartment syndrome or something that looks like a compartment syndrome is probably our most concerning problem, and rhabdomyolysis. And here's just some folks that have had fasciotomies, and traditionally, particularly in some parts of the U.S., before the wide use of antivenom, the primary approach was to be a surgical intervention with the swelling, and patients had very disfiguring surgical procedures, which with antivenom are probably not required. And estimates are maybe 1 out of 100 cases of envenomation, require some sort of surgical intervention, whether it's a dermotomy or occasionally a fasciotomy, but this is very uncommon. Of interest, though, in certain parts, as I just alluded to, in Texas and elsewhere, the traditional approach was the fasciotomy, and that's why where the patient gets admitted in the hospital, it really does make a difference. If there's a toxicologist, if they're admitted to a toxicology service, we tend to primarily use the antivenom. But in other hospitals without toxicologists, they see swelling, they say it's a surgical problem, they may admit the patient to a general surgeon, and they may end up with an unnecessary fasciotomy. So
in the U.S., it's a trauma code.
Trauma.
Yeah.
Yeah. So in terms of antivenom, again, unlike my Indian colleague who's really saving lives with antivenom, these patients, almost all of them, are going to live regardless. But when do we use the antivenom? So if there's progression of the swelling, again, limited swelling, we may not use the antivenom. And then hematological effects we use, and some of these rattlesnakes, a minority of them do have some neurotoxic effects, and any neurotoxicity would be treated with antivenom as well. Oops, went the wrong way. Okay, so different types of antivenom. So up until about 2000, the only antivenom that was available in the U.S. Was the old Wyeth antivenom made by horses. It was the whole IgG, and there were lots of side effects. It was very immunogenic, and many patients, in fact, the majority of patients, you gave them the antivenom, and they developed, significant, even severe reactions, anaphylaxis, at the same time that you gave them antivenom. That's why a little bit of caution about, just moving and giving antivenom to everyone just because of all those side effects. And there were patients that in one arm you'd be giving them the infusion of the antivenom, and the other arm you'd be giving the infusion of the epinephrine to treat the anaphylaxis. So fortunately those days are behind us. And in the US, as you'll see in the next few slides, the main antivenom we had up until last year was the FAB antivenom, known by the trade name of Profab. And then the newer antivenom, which really just came out, is the FAB2 antivenom, which we'll discuss. So this was the old Wyeth that came from horses, lots of hypersensitivity reactions, including anaphylaxis. And traditionally, when we approach the care of patients, if something causes anaphylaxis, that's the last thing we use. If they have an allergy to an antibiotic that causes anaphylaxis, we never ever use it. But in the case of treating snake bites, this was the quandary. Not only the acute hypersensitivity reactions, but also the delayed hypersensitivity reactions. And most, if not all, of the patients practically would develop the serum sickness from the horse serum, which we see occasionally, but not very often now with the newer types of antivenom. So Profab came out in 2001, came from sheep. It was made by immunizing the sheep with certain venoms, so, the rattlesnake and also the cottonmouth, and it's just a very small amount of the FC fragment, so much less immunogenic than the IgG antivenom. It was is useful in stopping the progression of the swelling. At least that's one of the endpoints, and also to reverse the hematologic toxicity. There are a small subset of patients that develop systemic toxicity from snake bite, including hypotension, for instance. But those are really the minority of cases. Most patients have the swelling, which can be quite dramatic, and then a subset of those patients will have the hematologic effects.
Based on the clinical trials, it was John Sullivan who created it at the University of Arizona, and all the antivenom go back to actually our poison center. But even then, it was the clinical trials was on 48 patients, and it was on mild and moderate.
Right.
Never treated anybody with severe in that clinical trial. So.
And whether it prevents tissue loss or not, I mean, if someone presents already with necrosis, it's not going to suddenly reverse the necrosis and prevent that sort of tissue loss. Hopefully, it will prevent worsening tissue injury, but it doesn't reverse severe tissue injury by any means. So, in terms of dosing, I wish we could do this stoichiometrically. I wish we knew, the total amount of venom that was introduced and that we would calculate this based on the venom load, but we don't do that. So the way this antivenom was approved was to use a starting dose, and generally, we say 4 to 6 vials. With the old Wyeth antivenom from years ago, it was a larger number of vials, 10, 20 vials at a time, but this is a smaller number of vials. Whether you give 4 or 6, kind of depending on the severity of the bite. If it's more severe, I usually give 6. If it's less severe, but I want to use an antivenom, I give 4. And then you reassess the patient, and that's the critical thing that you need to do after the initial administration. You come back after an hour or 2 and you see what the swelling has progressed or not, and you measure the coags and the platelet count to see if there's been any reversibility. And we often see platelet counts that are very, very low, of 5 or 10. So if you give the antivenom and there is a good response, the platelet count will bounce right back up. The same thing with some of the coag factors, those can be totally depleted dramatically. So, although the patients tend not to bleed a lot, they just, you would expect them to be bleeding if the patient was on chemotherapy and had some sort of cancer and had those sorts of numbers. You'd be worried about head bleeds and other sorts of, really, devastating hemorrhages. But you don't see that much with snakebite. At least that's my experience. Then in terms of continuing to give the antivenom, particularly with the Crofab, as you'll see in the next couple of slides, there was this feature where the patient seemed to sometimes get worse again, or there was a delay, and because of this, the initial standard approach was to give them these extra doses, even as they recovered, just to prevent the late onset of other sorts of symptoms or the delayed toxicity, as you'll see. Whether that's required or not, it's still very debatable, and there's no standard of care. There's a recommendation under the package insert, but there's no standard of care. And I think in the last number of years, a lot of people have been deviating now from the traditional approach, which was used after the release of Crofab initially, which was to give this maintenance antivenom to patients. And again, one of the factors in terms of the decision making is the cost of it, if nothing else. Do you spend another $10,000 or $20,000 when the patient may not need any of this at all? So the problem with the Crofab was the pharmacokinetics and the fact that the half-life was relatively short. And so the effects of the venom, in some cases, were outlasting the effects of the antivenom. And because of that, you would sometimes see this late onset hemotoxicity, which was certainly of interest in terms of how long do you observe the patient for after the treatment. And then the other problem was the recurrence. And so patients seem to recover, you'd send them home, and then 2 days later, you check their blood counts again, and their platelet count would be back to 10,000, and you'd say, well, they seem like they've had a late venom effect. Do they need to come in for retreatment? And these were the decisions that need to be made. So, particularly with the rattlesnakes, less so with the copperheads, the approach is to follow them up after discharge from the hospital to test their coags and their platelet count again, and to follow them closely. And if they had an isolated coagulopathy, we wouldn't necessarily treat them. Again, many of these patients, most of them never bleed anyway, so you're treating numbers. But if they have 2-compartment coagulopathy or thrombocytopenia, for instance, or platelet counts that are real low, then we may treat them. Whether there's data to support that approach, there is none. But this was kind of a gestalt that those who treated these snake bites felt like, well, do we leave these patients to go home with platelet counts of 10,000? It's dangerous. What happens if they fall and hit their head? We probably should retreat, but again, based on anecdotal information. And these are some other risk factors for bleeding as well. So moving on to the newest antivenom in the U.S. is the FAB2, which those of you from India and elsewhere have much more experience with. This was under clinical trials, and a long delay to the release for many years. Some of the clinical trials were done literally 6-8 years ago, but it wasn't released until late in 2018. And the potential advantage of this antivenom is that it has much slower clearance. It hangs around for a lot longer period of time. So these were a couple of the studies done during the clinical trials. It's only been released, like I said, in October 2018, so there's really practically nothing published yet since it's been released. But there are a number of folks studying this, and there should be a lot more papers coming out in the next few years about the use of the antivib and also comparing the antivib with the Profab to see whether there's truly a difference or not. So this was from one of the early clinical trials, just really a couple handfuls of patients comparing the two groups. But the group that got the FAB2 seemed to have more detectable antivenom when it was studied further out than the group that just received the Profab. So at least on paper in these small series, there seems to be an advantage, and we'll see what happens in the future. Now, in terms of the use of particularly the FAB2, that was approved for the treatment of rattlesnake bite, and actually not copperheads, which are less venomous, as I described, but we have a lot of copperhead bites in the U.S., and so whether it will be used off-label, like a lot of things are used off-label for the treatment of copperheads, will still be to be determined. The typical starting dose for the antivib is thought to be about 10 vials. And Masa, you have a lot of experience now with the antivib. You usually use 10.
We have used it. It looks like for mild to moderate 10 vials, and then anything more than that, you actually need to repeat it.
Yeah, okay. So again, all this will be coming out. So I just want to close with this one little case, and I continued to learn about toxicology with my travels. So this was a patient who was bit on the toe, but it turns out he did not have much in the way of local tissue effects because it was a crate bite, and as was described very eloquently, had severe effects in terms of the neurotoxic effects. Ended up on ventilators. The patient on the right was really interesting because when it was presented to us on rounds, they said, well, we have no idea whether he's bit by a snake or not, but he presents like a crate bite. He's unconscious. He's a young guy. He's healthy, so we're going to treat him as such. And because of that, they have really good success in treating this patient. Yeah. Yes. Yeah.
This is what as I said, that in that particular time period, any young person who comes with this kind of a symptom, I might end up over-treating a couple of them, but I would treat them.
Yeah. And this is the antidote that's used.
Yeah.
So thank you very much. Any questions? Yes.
Yeah. So what's your experience with the delayed coagulopathy from the rattlesnake? I know there's also some evidence if they presented like delayed 2 days later and the role of loading antivirus at that point. So do you see a lot who do not present initially with coagulopathy and then like 2 days later have delayed coagulopathy?
Well, there are some, and the initial dosing of the antivenom with the Profab may mask the coagulopathy. And once it wears off, then it presents itself. And I think that's the issue. They come in, those patients, they come in really early, they have swelling, you check their blood count, it's normal, you give them the Profab, and then 3 days later, you have to send them home, and then you check your platelet count, now it's very low, or the PT is very high. And the question is, well, why wasn't it like that at the outset? It's probably because they were treated so quickly.
50% of the patients that present to us are coagulopathic, defibrinated or platelets that are below 150, and I guess, by consensus, we decided that that's thrombocytopenia in the snake bite. Of those, 75% will go to develop recurrent coagulopathy in our care. Now, Paul is correct. Majority of the Arizona population in the city are within an hour of presenting to a hospital. Now, our understanding, because our center takes care of most of the rural Arizona, we see the same thing even when they present later. It is 50% are coagulopathic and 50% are not. And you can't predict which ones are going to become.
Yeah,
And
this
the longest we've seen has been 82 days. 82 days of platelets under.
And does not have to do with the reabsorption from tissue?
There are lots of theories about why that happens, that whether there's a depot or not, or maybe that individual is, when we're talking about now smaller individuals. We follow them up to 21 days, and then we call them every 6 months up to a year out, just to look for local damage on the, because we get lots of local damage and they need grafting when it's on the tissue of the fingers and toes.
How often did you experience anaphylactoid reaction? I mean, in Atlanta we had mostly copperheads, so we didn't much recommend it. But how do you often really see it? I mean, we talk about that.
Well, with the ProFab, I've yet to see a case of true anaphylaxis, but it's been reported. But that has to be compared to the prior experience where anaphylaxis was happening about a third of the time. I mean, with the old horse serum, and that's why, we're very cautious about the potential of developing adverse effects. But the number of adverse effects with the FAB is much lower.
The total reactions is actually there are good publications on both from Phoenix, Tucson, and it's less than 0.05%. All reactions, not anaphylaxis, but all allergic reactions with CroFab. With the now, if you're talking about anaphylactoids, we see that all the time, and that's rate. If you start giving the antivenom really fast, especially in children, we see lots of anaphylactoid. We just slow it down.
Questions? Okay, perfect. Thank you very much. So now the real break.
Break.
And do insurance cover the venom?
Most insurance are, if you don't have it, goes up Medicaid.
But they have to pay some percentage, right?
No.
Treat snake bites. Within the season that we have, we see about 50 snake bites at bedside, and then we treat another 70 in the hospitals that are under our care. So the most common types of coagulopathy that we see with snake bites are defibrillation and thrombocytopenia. Now, thrombocytopenia has been explained in many ways. That is it due to demarginalization? Is it due to clumping? But that's something that we see that immediately is reversible, almost. So platelets are almost gone, individual comes in, and again, we do not run into the problems of people presenting late. Now, do we have late presenters in terms of snake bites? Yes, but those are volitional. One individual, for example, did not come in for 2 weeks because he didn't feel he's sick enough. And again, our snakes do not kill you, right? Our snakes are rarely kill you. And you can look at the rate. We did a study with Frank Walter, myself, and we published the rate of snake bite deaths in the US, even when you include the elapids that we have, it's almost rare. It's a rarity, okay? And again, access to ICU care, access to ventilation, almost, if you have that type of care, nobody dies from it. But thrombocytopenia we see early on. It's reversible both with CroFab and now with Anavib. So both with antivenom that is Fab1 and antivenom that's Fab2. Remember, lots of people talk about antivenom snake bites, but they don't treat them on a regular basis. Antivenom Fab1 came to be why? Why did we come up with the Fab1? There's only 2 Fab1. There's a European and there is an American Fab1 anti-snake. The whole idea was they have better penetration into tissue because we were worried about tissue toxicity. And I don't know, Bruno, do you guys have a Fab1 in France? No, we have a Fab2. Fab2 is actually a better antivenom in terms of lasting and being effective. But what we see is a different problem with it. Now we're talking about coagulopathy. Platelet reversal we see almost the same with the antivenom that's a Fab1 and antivenom Fab2. So people come in, you measure their platelets, it says 30, 60, undetectable. You give them antivenom, back to normal, right? Now, are they as effective, meaning functional? Most of the functional studies that are done, whether you're talking about epinephrine activation, collagen activation and stuff, they do not show any difference. There are shear activation studies that show that maybe in a snake bite, depending on the venom, that the activations are not one and the same, meaning platelets are not functional as they were before seeing the venom. Now, the other thing that we see is defibrillation. So fibrin is totally gone. It is interesting that with antivenom that was a Fab1, we would give it, and it would take almost tens of hours before we could see a detection on the levels of fibrinogen. Okay? So what happens? Fibrinogen, if it's destroyed, right, then it takes time to regenerate it. You don't all of a sudden come up with fibrinogen. I would tell you, our early studies and looking at the Fab2, we see a different pattern. And I don't have an explanation yet for it. We give Fab2, and what do we see? Return to normal. Why? I don't have an explanation for it. Is it that somehow the venom actually is enveloping fibrinogen and other factors, and they're not seen based on the assays that we're doing, and now we give the antivenom and you can see it? I don't know if those studies have been done, but I know that you guys have been using Fab2 longer than we have. And are you seeing anything with fibrinogen and other factors? Do you measure it?
Yeah, we do measure them.
And what do you see with the Fab2?
Yeah, a few hours.
Return to normal?
Going up.
They start going up. But do they return to normal?
Yeah. Yeah, fibrinogen. Yeah.
So fibrinogen you get somebody that comes into the hospital, fibrinogen undetectable. You give them antivenom, and now they're normal. Is that what you're seeing?
But not within within few hours. I mean, within a few hours you start to see it going up. 6-8 hours you have some.
Because our protocol basically we don't measure after 2 hours. We measurement is mainly after 6 hours, 6, 12, 18 hours.
So we do it an hour before and an hour after infusion. So, Bruno, what's your experience in France?
With
the fibrinogen. So one thing that we're seeing now with this new Anavip, which is a Fab2, fibrinogen, we used to see it go down, and we get Fab1, it would not affect it. Maybe 6, 7, 8, 10 hours later, it would start going up.
Let me ask you first. Did you see any difference for the local reaction between the Fab1 and Fab2?
What do you mean?
Local reaction.
No.
Because
we're not seeing any.
We know that when you give antivenom, Fab2, right, it doesn't go well to the tissue. Mm-hmm. So the tissue reaction is called inflammation, right? Mm-hmm. And fibrinogen is the acute phase reactant.
Correct.
Yeah, and we see that when the patient have really bad local reaction, it's gonna increase fibrinogen. That is the factor that counterbalance the venom. The one who has severe reaction, those patients have high level of fibrinogen, very early on.
So we see that with, for example, when we were talking about antibiotics, okay, people who come in and they have high levels of fibrinogen,
yeah,
and I'm talking about 600 to 800, we look at them and they have an infection already. something going on. And majority of them, they've done something. They manipulated the wound, or they were out of care, and they were not sanitary, and they do have some sort of infection. We looked at 2,000 snake bites and showed that nobody needs antibiotics unless they've done some manipulation of their wound. Now,
at what time did you diagnose infection?
At what time we diagnosed infection?
Yes.
Well, the whole thing was in the EDs, a diagnosis of infection, I better do prophylaxis.
I know, because usually
we do not do.
Venom can cause local reaction, right? Inflammation is not infection in the first few hours, like up to like 6 to 12 hours. It's not possible. Infection can happen within like 6 to 12 hours. So if you diagnose infection in 6 or 12 hours, it would be not that infection. It should be inflammation from venom.